Good morning, everyone. Corneal inlay for pellucid marginal degeneration. So PMD is a rare bilateral corneal ectatic disorder associated with inferior arcuate band of thinning 1 mm from the limbus. It's a progressive condition associated with acute eye drops in advanced cases. Cross-linking causes biomechanical stabilization, hence it's useful in mild or early PMD, whereas in moderate and severe cases, surgical intervention in the form of lamellar procedures is required. Here we propose a novel surgical method of placing an inferior intrastromal corneal inlay as a structural intervention in the management of PMD. Aim to evaluate the efficacy of donor corneal stromal inlay in disease stabilization in patients with PMD over a 2-year follow-up period. So patients diagnosed with PMD with the inferior corneal thinness pachymetry less than 400 microns as measured on AIOCT were included in the study. Uncorrected visual acuity, best corrected visual acuity, refraction, IOP, pentacam and AIOCT were done, and patients are followed up at 1 month, 3 months, 6 months, 1 year and 2 years. Statistical analysis was done using IBM SPSS software, and differences between any 2 points were analyzed using paired sample t-test. So here is surgery, an intrastromal allograft for PMD. So either a limbal incision or a clear corneal incision can be made, and using a crescent plate, the inferior part of the cornea and intrastromal pocket is created. So this has to be done very slowly and gently in order to prevent either a buttonholing or a perforation. So in this case, to extend the intrastromal pocket, lamellar dissectors can also be used. Here we've used a straightened crescent blade, and it's important to reach up to the opposite limbus. So meanwhile, an donor corneal graft, which is trimmed around 300 microns, is inserted into the intrastromal pocket with the help of a Sinski's hook. Once this is inserted, the section is closed with 10-0 nylon sutures. So preoperative marking of the inferior corneal thinning can also be useful in these cases, and all patients postoperatively received moxifloxacin eye drops for 1 week and loteprednol eye drops, which was tapered over 1 month, and all patients underwent suture removal at 1 month. So this is a preoperative photo showing PMD with the inferior arcuate band of thinning, and on the right you can see the presence of the corneal inlay. So AIOCT preoperatively, patient had a thickness of around 390 microns, and postoperatively this was at 1 year that you can see the presence of corneal stromal inlay. This is another patient who had an extremely thin inferior pachy of around 230 microns, and this was taken on POD1, where you can see the presence of the corneal inlay. So pentacam, again on follow-up, example of one of our patients at pre-op, 1 month, 3 months, 6 months and 2 years. You can see the astigmatism here becoming more regular at 3 months itself, and which was maintained over a period of 2 years. And inferiorly, there's good tectonic support because of the addition of the corneal stromal inlay. So these were a few other cases that were done as a part of this study. Results: surgery was performed in 10 eyes of 9 patients. The mean age of the study population was 44 plus or minus 13 years. The study included 5 males and 4 females. Visual acuity: there was no improvement in the uncorrected visual acuity or spherical refraction. It was not statistically significant. Whereas there was an improvement in the best corrected visual acuity from pre-op to 1 month, as well as an improvement in cylindrical refraction from pre-op to 1 month, which was stable until 2 years of follow-up. Pentacam, analyzing the topographical astigmatism. From pre-op to 1 month, there was a decrease in the topographical astigmatism. Again, from 1 month to 3 months also this was noted, and this was maintained from 3 months to over a period of 2 years. AIOCT, in the mean age AIOCT, that is a mean thinness pachymetry at the inferior limbus among our patients preoperatively was 364 microns plus or minus 27 microns, and at 2 years it maintained at 652 microns plus or minus 90 microns. So discussion: in PMD with the inferior thinness pachymetry greater than 400 microns, cross-linking followed by rehabilitation with glasses or scleral contact lenses is a good management option. Whereas in patients with thinness pachymetry less than 400 microns, either a DALC, tuck-in DALC, crescentric lamellar keratoplasty, both full thickness and lamellar have been attempted. However, the above procedures have been associated with suture-related complications and high residual astigmatism. Hence, placement of corneal inlay could be a good structural intervention in disease stabilization in this group of patients. The outcome being increase in the inferior corneal thickness, stabilization of cornea by adding a tectonic support, thereby preventing eye drops. And this also enables early visual rehabilitation with glasses, spectacles, better fit with scleral contact lenses, and phakic IOLs. Advantages of the procedure being there's no endothelial rejection, no suture-related astigmatism, no wound gaping, no requirement of long-term steroid use, hence avoiding steroid-related complications. A single donor cornea can be used for 2 patients. The leftover peripheral corneal button after central trephination can also be used for the corneal stromal inlay. Disadvantages of the procedure being creation of intrastromal pocket in already thin corneas becomes very challenging. There's always a risk of perforation and buttonholing. However, in our series, we did not notice any of these. Intraoperative OCT in these cases can guide the surgeon to prevent these complications. Conclusion, corneal inlay could be a good and effective surgical option in moderate and severe PMD for structural support and disease stabilization, thereby preventing acute eye drops. These are my references. Thank you.
So what was the average change in spectacle cylinder and keratometric cylinder pre and post procedure?
Spectacle cylinder around 1 diopter, sir. Around cylindrical
That's
astigmatism.
what I was seeing, like you had, I think 9 diopter pre-op and 8 diopters post-op.
Yes, sir.
So
Around
1 diopter shift with so much of surgery is very less, isn't it? I mean,
Yeah,
how did it help finally? They may still need a contact lens or something.
So
like
the aim of the procedure is not visual rehabilitation. The aim of the procedure is just disease stabilization. So that post placement of corneal stromal inlay, like placement of scleral contact lenses, getting a better fit becomes easier. And you know that the disease is stabilized. So if the patient has got cataract, like because we still had 50, 55-year-old patients with cataract and PMD. So they underwent the procedure and then later they underwent a toric IOL, customized toric IOL implantation. So the aim of the procedure is not to increase the vision or it is just for disease stabilization. So later visual rehabilitation can be done in these patients. Some are bilateral patients which are very comfortable with scleral contact lenses post-procedure. And one patient even underwent phakic IOL after the procedure.
Because some of these surgeries for PMD have been designed to improve or at least reduce astigmatism, although their long-term, there is a drift again back to ectasia or maybe, you know, the procedure cylinder.
That's why we aim at disease stabilization. So at least for almost 2 years of follow-up, we did not have any increase in cylinder, not even in one of the patients. So the aim was disease stabilization followed by visual rehabilitation.
Okay. Thank you.
So how you calculate the thickness of the donor graft?
So donor graft, we placed it on the artificial anterior chamber and using a 300 micron.
Thickness I am asking. The inlay graft.
What? Yeah, we place it on the artificial anterior chamber and dissect at 300 microns level.
300 microns.
Yeah.
Thank you.